what I'm going to introduce is a short talk on the thoracic and abdominal injuries. And as you know, sometimes we do come across any one of these various conditions, and depending on the severity, it could be a small laceration and it could mean nothing in an outpatient to having a laceration that loses enough blood that we've had to replace it. And that's how the gamut is. The whole thoracic surgeries can be very, very this thing. You just need to be tuned on to how much and when to intervene and what to do. You could have rib fractures and you could send the patient out from the outpatients, and you could have rib fractures with a child in distress with hemopneumothorax who would require chest tubes and maybe have some soft tissue loss and who would need to have a chest tube immediately, need to be ventilated and have a stomy course. And similarly, great vessel injury, which we rarely deal with, which go to this thing, but in our setup, they rarely reach the hospital. And blunt thoracic trauma, more common, and so we do see all of these at some stage or the other. We've seen several of these tracheobronchial injuries. Surprisingly and good for us that a minor tracheobronchial injury will have some subcutaneous emphysema, but fortunately will settle down. But major injuries require something to be done for them, which fortunately we don't see that many. And esophageal injuries are something that I've seen, and they come and they are notoriously difficult to treat. And there's one such X-ray and a gastrographin study that I'll show you of a child, and there is a high morbidity. I think it's morbidity and mortality. I think if you see esophageal injury, I mean, you really need to be on your marks. Other thoracic injuries, you could have a cardiac injury. Fortunately, in children, we don't have that many gunshots and wounds that I have seen during my training in Punjab, when we used to have lots of fights over land and women, and we used to have lots of Sardarjis coming with gunshots everywhere, but we don't see them in children. We would have, so we don't see those pellets and other things, but yeah, we can have pericardial tamponade, and you need to do a pericardiocentesis sometimes, and surgical intervention as and when required. Okay, the common things are rib fractures, subcutaneous emphysema, and hemopneumothorax. Let's talk about common things. And what do you have? You have pain, the child comes in, I mean, he might even not be breathing properly because he's got severe pain. And before the advent of pediatric intensivists, it was left to us to look after these. And it was a hard time trying to put in a chest tube, trying to take care of the pain, get someone to please see if the child is breathing normally. And it was a Herculean task to get these children out of trouble, which with the advent of our colleagues now, thanks, and all of you are here to help out, it makes life a lot more easier for us. So I think the most important is we need to take care of the analgesia and narcotics and put in tubes as and when necessary. It's very rare that we need to rush in a child with an injury straight into the OT without sorting out everything else. And that's most important. So depending on what and where the injury is when we intervene. And some of them are not entirely traumatic as an outside. Some of them are even putting a chest tube. I mean, I was in one of the hospitals just about 2 weeks ago where a chest tube put in, and it's just incidental. It was a very enthusiastic intensivist. Actually damaged the diaphragm and needed, lost 5-6 liters of blood. Of course, there was a bleeding profile was deranged. But, it was a massive, massive injury. And so these things can happen with simple things as well. So we'll go on to, here is an X-ray which I think Dr. Uttam will recall, and Dr. Khilani. We treated this child when we were this is at Apollo. Is that working? Yeah, okay. So, this child actually was from Bihar, and he swallowed 2 1-rupee coins. You can see one, and it was hard to believe that it was one, but there were 2. The history was clear. This child was 11 years old, and he swallowed the coin there wasn't any anesthesia given, but a rigid endoscope was put in, and they tried to remove this coin, and some sedation or whatever. Anyway, this child perforated and then came at usual 11, 12 at night from Bihar. He reached, the hospital at night. In the emergency, I did the barium swallow, and you can see this esophagus leaking, and this is where it's not showing, the coin is within that, large rent in the esophagus, and this is all leaking into the pleural cavity. Anyway, the good thing is that this child survived after 3 weeks. All I did on this child, we put in chest tubes, and incidentally, there was even the next day as we were, overnight we stabilized the patient, and we said, okay, we'll take him up, thoracotomy, take out, because it was already like 36, 48 hours. He was running fever, we'll take out the coins. And here's this child who also has now his abdomen getting tense. And lo and behold, we actually found a duodenal perforation. Till this day, I don't know how that rigid esophagus went in, and esophagoscope or whatever went in and actually made a hole. I still don't know, but I found, and all we did was a feeding jejunostomy, did not try to repair that esophagus because I knew it would not take any stitches. Just drained all the pus, closed the duodenum over a couple of tubes, and fed him through that jejunostomy. And this child went home in 5 weeks. I don't recall, but I think he wasn't ventilated. He was in the ICU for a long time. And I think that is what we are talking about. If we can get together on such a child. And incidentally, this child came and met me 6 months ago, and he's now 18 years. And he said, you recognize me? I said, no, I don't. Tell me your name. The moment he said, I said, oh my God. He says, I'm the same kid. I'm now a grown-up boy, and I'm fine. So that's where, it's really very, this thing when we have this kind of, this child, somebody just slapped him on the back. And when they slapped him, this is what we found. There was, and he said every time he ate something, he was choking. He developed a traumatic tracheoesophageal fistula. I mean, we could bring the two ends together, but they were tending to stenose, and he needed to go. Then he left us because of different reasons, the corporate, and went to the government sector. But this child, clearly there was a history, an acute history of having trauma, and just a big blow at the back, and developing esophageal perforation, and this. And recently I saw another child whom I treated who also had a very torrid course, luckily did well, and that child was 1.5 years, and the only history was that she was perfectly all right for about a year, and then suddenly she went to some wedding and somebody gave her something and she coughed a little bit, and since then she had dysphagia, and dysphagia turned out to be and she had a stricture at T3, T4. And we don't know, there was no other history, 10 dilatations, 1 perforations, and then I went in to repair that. Fortunately, she did well, but she had to be in hospital for a month and needed long ventilation and every conceivable problem. But it's good to know that she's doing well now. So coming now to the abdominal trauma, I think this is just a listing of all the organs that are possibly there. But just to come back, I think the common things, the blunt injuries, the solid organ injuries, the spleen and liver, over the years we've had, a revolutionized treatment because we try and wait on them as long as possible. It's not easy to wait on these, but I think that's important. The other situation, and there are some 1 or 2 photos that I'd like to show you after this, the abdominal trauma, we have what are we going to do? You have a child who has abdominal trauma. What is the first investigation? I still believe an X-ray, a plain X-ray, is mandatory and is most useful because we get to know just too many things in that. I mean, if we can see air on the diaphragm, fine, but if the child is sick, do a lateral decubitus. And that is just next ultrasound because it's easily available. You can pick up, a good ultrasonographer can pick up injuries in the liver, injuries in the spleen can be picked up, and then you can go for a CT because CT takes longer to organize, there is radiation, and if the abdomen is soft, I would not necessarily go for a CT for every child who comes in with trauma. This is this thing, and a lot of time it's often a child in our situation. I've seen several children who've fallen off the roof, people have made new houses, and they are those novo-rich who made the houses but haven't made the parapet around and they've fallen off, and usually it's a call from a neurosurgeon saying, please rule out chest abdomen trauma. I wish I had a magic wand to say that this child has no chest abdomen trauma. So the only way to go is to actually put your hand on that chest and abdomen, on that abdomen, and then see after the ultrasound whether you need a CT. It's a hard decision, but you need to currently we are going away from the paracentesis, which we used to do almost routinely. And what we are saying is, when you're strongly suspecting that there is some injury, put in a laparoscope and do that. That is faster than if and faster and more accurate. Okay, so what we are saying is just saying that if that abdomen is going up, definitely you are not going to wait for any investigations, or there is a gas leak, you need to put in a tube immediately. Just to give you an example, a colleague of mine was doing a procedure on an endoscope with an esophageal. There was some hemangiomas and some lesions, hemangiomatous lesions in the stomach. So he was just going to do a laser puncture on those lesions, and he says, "But I'd like you to stand by." So I stood by him, but I needed to intervene because it seemed all smooth, and suddenly the anesthetist said, "I can see the abdomen going up and I can't seem to ventilate." What had happened is, whether the depth of the laser or whatever, wherever it touched, there were those multiple holes in the stomach, and suddenly the abdomen was here. So all I needed to do at that time was, he said, "X-ray." I said, "No X-ray, we are not waiting for any X-ray." So all we needed was make a small incision in that stomach and let that air out. And here was a child who was ventilating, and we subsequently closed those holes. But it can happen with the simplest of things. Splenic liver injuries, I would rarely go ahead unless it's totally shattered spleen. You take it up for surgery. Okay, otherwise not necessary. Here is a newborn, and this is a baby who actually did not survive, but what the cause was, we don't know. The baby came in very sick, and this is from a community where we know, or a particular sect of people where we know there is some child abuse, although it's a male baby. But I don't know what happened, because I have seen some from here who've been injured and they say no history, and I said, if there's no history, how do I get a diurnal perf? And many other things. But anyway, this is sometimes, very rarely, but we do see this. These are three sort of CTs in serial. This is interestingly a patient whose parents own a medical college in Lucknow. And they came with a shattered spleen. I think Ravi's here, maybe Ravi was involved and Dr. Khilani was involved. Totally shattered. This is the stomach, and here you can see there's blood inside. And why they came to Delhi? Because they had said, we're going to take this child to the theatre. So I said, okay. Hemoglobin obviously dropped. We said, hold on, we'll do a CT, we'll hang on. And there was CT1 already done, all the blood collected. And I said, no, this child is clinically stable. We are not going to open this abdomen unless and until we are forced to open. This is something I can only do in a setup where I have an intensivist. Otherwise, I would have probably been safer to open and be done with it. But here we lasted out for 9 days, and this is the same child, and ultimately this child, gradually the hematoma was absorbed. She required about 3 units of blood over 8-9 days, and finally she went home. So if anyone needs a medical college admission in Lucknow, they are the people. So this is the second one. I think we had a series, all 3 came within a month. Another one who had a liver injury, and you can see all shattered, this thing. Again waited, ran away from another hospital because they're talking about surgery. This is another one, was from a criminal belt, and they couldn't do the CT, so they came across, and I said, no, hold on. And all 3 went home without any surgical intervention. So I think what we are saying is that if we are holding on, it means we need to do a continuous surveillance, and we really need to stretch ourselves out to have a very good, understanding that if we need to go in, we go in any time. We don't hold on, as long as we have everything ready, blood is ready, the theatre will be available, then we can sit on these, provided blood pressure, pulse, everything is doing fine. So the general principles of trauma, which I'm really just going to, skip this slide just for the completeness of the talk, is everyone is known this. And I think the next one is, because since we have a pediatric intensivist who's going to talk after me, I'm not going to go into any details on how much fluid, when and what. So over to Dr. Rajiv Uttam. I think I'd complete my talk here. Thank you.